Welcome. Good evening. Welcome. I would like to welcome you on behalf of the European Association of Neurological Societies, another webinar from the EANS CSF section. We have a wonderful team, researchers that do the actual research and report, specialists, and we have a wonderful team that is moderating it. So I will hand over to the moderators. Please do not forget to ask questions and to put them in the Q&A box, and please enjoy the wonderful evening. So please.
Good evening from me as well. I'm happy to introduce today's panelists who will present on idiopathic normal pressure hydrocephalus. We will hear from persons who have more than 20 years of experience in iNPH, and I'm really happy to have Mats Tolberg here and Kerstin Andren. Both are from the Gothenburg University, from the Hydrocephalus Research Unit. Mats Tolberg is the director of the Gothenburg Hydrocephalus Research Unit, president of the Hydrocephalus Society, and he's a lead member of the Swedish Hydrocephalus Quality Registry. Also, he's kindly enough to be member of the EANS CSF section panel and has started his PhD studies in 2001 already, learning and researching on iNPH. After that, he performed a postdoc fellowship at UC Davis in California and continues his specialization in research and clinical care of iNPH. Kerstin Andren, she's a PhD also from the Gothenburg Hydrocephalus Research Unit. She did her thesis on natural course and long-term evolution of iNPH in 2020 and is a consultant neurologist. We're so happy to have you here, and I'm also very happy to moderate this webinar with Mansoor Faruqi, whom you already know. And from there, I would again like to remember you put your questions to the Q&A section. We will have our first talk by Mats Tolberg, followed by Kerstin Andren and short discussions in between. So Mats, we're very happy to have you here and to get to know your work.
Mats, you're on mute.
Mats, we can't hear you.
Mats, you may be on mute.
See if you can hear me now. I'm sorry you lost me.
Yes, we can hear you. Thank you, Mats.
Yes, I want to thank you for inviting me and for giving me and my dear colleague and friend Kerstin to give you these talks about idiopathic normal pressure hydrocephalus, and the focus of today's webinar will be clinical symptoms of idiopathic normal pressure hydrocephalus and their use in diagnostics and prediction. Both me and myself and Kerstin are neurologists, and I can say from the beginning that working with iNPH is fantastic because it's a very, very fascinating disorder for a neurologist, and I hope I can share some of my enthusiasm while showing you some of the experiences we have gathered during the years. I've been working with iNPH since more than 30 years now, and I'm still as fascinated as in the beginning, really. So these are my disclosures and just a short presentation of the setting and where we work. So this is Sweden, as you may see, northern part of Europe. Gothenburg is situated here on the west coast, and we serve the western Sweden with around 1.7 million inhabitants. Sahlgrenska University Hospital is the university hospital of this region, around 2,000 beds. And we run the Hydrocephalus Research Center for adult hydrocephalus. At the moment, we have more than 700 referrals for hydrocephalus per year. and we perform shunt surgery in, I think 120 will be the next figure here, patients per year. And I can just mention that we have an increasing inflow of referrals, and this illustrates that iNPH is today really an underdiagnosed disorder. We will not have time to talk a lot about that, but we see an increasing number of referrals, and we see the same patients. So we are still shunting many of the patients we see for workup. So it's not a change in patient characteristics, rather more patients being discovered, which is very positive, of course. So my talk will focus on the clinical syndrome of iNPH and some of the characteristics of that syndrome. I will illustrate this showing you some videos, mainly of gait, but I will also talk about other symptoms. And the bottom line is that there is really a clinical syndrome of iNPH, according to us. This is a famous picture, as you may know. We will move on now from the early 20th century to the middle of the 1960s, when this disorder was discovered. And why do I show this? Well, this is the headline of the first real scientific article presenting normal pressure hydrocephalus as a new disorder, characterized by 3 symptoms: gait, mental, and urinary symptoms. And this coined the term Hakim's triad. So 3 main symptoms of different modalities. But what we would like to post is this, that Hakim's triad is in fact a tetrad. It consists of 4 symptoms. And why do I say that? So if you want to describe the characteristic symptoms in the syndrome of iNPH, you can talk about these 4 domains. So it's gait disturbance. That is what the disorder is famous for. But it's also impaired balance. And of course, gait and balance are closely connected, and they affect each other. But in the clinical setting, you see patients with more of gait disturbance and less impaired balance. But you also see patients with a reversed picture, where it's the balance that is more impaired and the gait is less affected. So in the assessment we do examinations of gait and balance separately, because these are 2 different aspects that should be considered. The third symptom is the cognitive deterioration, and the 4th is the urinary urgency and incontinence. And if you look at these 4 domains of symptoms, it is easy to recognize that gait and balance, those are 2 domains that are common in movement disorders. So iNPH is a kind of movement disorder, just like the Parkinsonian disorders. We have cognitive deterioration in our patients, and some become demented. Some have less of cognitive deterioration, but this also means that iNPH is a cognitive disorder, a dementia, that must be separated from other dementias like Alzheimer's disease. The urinary urgency incontinence is related to urological or gynecological disorders, and that may mean something for differential diagnostics. I will not have a lot of time to go into that. Rather, I will focus on the typical symptoms here. Okay, so 4 different types of symptoms. What we know is that these symptoms are more or less interrelated. So if you have much of the gait disturbance or balance disturbance, you usually have a lot of cognitive deterioration and a pronounced urinary urgency. Not in all patients, but in most of them. Another thing is that it's not only the gait that is affected, it is more of a general motor impairment. So we also see slowing of motor movements in the upper extremities, just like in Parkinsonian disorders. And the bottom line here is that if you use a dedicated workup, you can usually distinguish this clinical syndrome and separate it or distinguish it from other kinds of disorders. So again, gait, balance, cognition, and urinary. So how often do these present? Well, there have been many studies over the years. I will just present data from one of our recent studies published in 2018, where we found that 90% of those diagnosed with iNPH had a gait disorder. And you may ask yourself, if we use the current guidelines, why isn't gait a prerequisite for the diagnosis? Yes, it is today. So the tendency is, of course, that you find gait disturbance in 100%. But in this study, we had also included patients diagnosed before 2005 from our database. And while we are working on new guidelines, we will have to decide if gait really is mandatory, which I don't think it is. But gait is the most common of the symptoms. Balance, in this study, 53% suffered from balance impairment, defined by test results. Cognition was impaired in 53%. There are patients with no cognitive impairment at all, but severe gait impairment. And urinary urgency and incontinence was present in 86%. And some patients, or many patients, think that this urinary incontinence may be the most disturbing symptoms of all. So it's really important to assess. But these figures corroborate other studies like these two. Looking at the number of domains affected, if we look at these as 4 domains, we found in this study that 41% had symptoms in all 4 domains, 31% in 3 domains, 2 domains in 19%, and 1 domain in only 9%. So the most common thing is that you find the impairments in all these 4 aspects. Okay. When you see a patient with suspicion of iNPH, the first thing you need to do is to take a medical history. And as a neurologist, that is what we are used to. And I can really advocate that you spend some time on this, because this helps you a lot in your diagnosis. And you should have a next of kin, usually the closest relative, coming with the patient, because if you have a cognitive decline, it may be difficult for the patient to describe the development of symptoms. The usual thing is what you see is the gradual progression of symptoms, starting very, very slowly or slightly, and then over time developing into more severe symptoms. As these patients are usually old, they are usually around 70 or slightly above. Many patients consider aging to be the cause of the decline, until they find that they are so impaired that this cannot only be age. Usually it starts with gait and or balance. Some experience balance difficulties as the first thing, like walking in the forest or standing on a boat or something like that, tendency to fall, and then comes the gait. But it can also be the other way around. Usually this is followed by the cognitive decline, mainly a memory problem from the patient's perspective, but relatives can also see other aspects like impaired initiative, problems coping with different things, slow mental functions, etc. The urinary urgency and later incontinence also progresses gradually and can start any time, usually after the progression of starting of gait and balance. And in late stages, you can also find fecal incontinence. One thing is that symptom duration may be very long, at least a few months, usually years, and up to 10 years is not very uncommon at all. And the very interesting thing is that you can face a patient who have had symptoms for 10 years, and when you do a TAP test, you can reverse symptoms within hours, which is really the thrill for pathophysiology. I don't have time to go into that. Okay, after you're taking the history, you should, of course, look for specific signs. And the first thing you should start with is to try to find the characteristic features of gait in NPH. And these statements should describe the typical pattern. So it is a broad-based gait with the width between the feet increased. The velocity is reduced. Usually patients walk slowly. Their relatives may complain that their husband or wife walks very slowly. The stride length is diminished, so short stepped gait. And there is a reduced foot to floor clearance in typical cases, which creates a shuffling of the gait that you can hear when you watch the patient walk. The foot angle is usually increased, so the feet point outwards, and you may also see freezings of gait. And contrary to Parkinson's disease, these freezings or irritations, gait arrests, can appear any time during the gait cycle, but also when walking through a doorpost or into an elevator or something. And sometimes it's difficult to distinguish these freezings from Parkinson. Other features are pronounced difficulties turning. So turning is very, very difficult, and there is also often a risk of falls during turning. So patients need to use many steps while turning to get around, and it's because the body is very stiff in a way. So it's a rigidity of the trunk and the lower body that makes the body has to turn in a non-fluent way. Another thing is that walking backwards is very difficult. This is not something patients do by themselves, but when asked to do it, we see that it may be so difficult that they almost fall backwards. Okay, is this specific? I would say yes. I think Kerstin agree. This is a famous study from Stoltz and colleagues in 2001, comparing in white bars NPH patients, gray bars Parkinson's disease, and the dark bars represent healthy controls. This study shows that on a group level you have these specific changes between groups. So the NPH patients have the lowest velocity, the shortest stride length, the greatest step width, foot angle increased, and the step height decreased. So at least on a group level, you can distinguish iNPH gait from both Parkinsonistic gait and healthy control gait. This is an illustration from our 3D gait lab, where we have a study. The red patient is preoperative gait, and the white is the same patient after surgery. And an interesting thing here is this is the TAG, the timed up and go test. You can see that the time it takes for pre and post-operative performance is not very different. The post-operatively it's a little bit faster, but not very much. But if you look at the quality, the red skeleton walks with very, very short steps, takes many steps. The cadence has to be higher. and then it sits down with a hard sit down. So this very much illustrates the change in quality that you get after treatment, where the white skeleton is, of course, the more normal type of walk. So what about postural dysfunction? Well, this is a movie I often show when giving lectures about this disorder. The typical impairment is a tendency to fall backwards or retropulsion. This is illustrated. Our physiotherapist Lippen some years ago had this patient, and this patient has a fulminant retropulsion, almost impossible to stand upright without holding something or a living person. She takes a few steps and then it's like something pulls her back. And not every patient shows this sign, but if we see it, it's very much a typical sign of iNPH. There are studies of balance in iNPH, some performed by our physiotherapists, but this is a study from the Umeå group looking at trunk sway in patients with iNPH, these bars, compared to healthy individuals and patients with unlikely NPH, ventriculomegaly patients. And you see that the sway is increased in patients with iNPH. So they tend to have a poorer balance. They have a difficulty finding the equilibrium in different tests. And this can be assessed very easily with the physiotherapy balance testing. Okay, so do all patients show all these signs? Well, I gave you the answer earlier, I think, but this bar figure illustrates this fact. This is from the same study I showed you earlier. A large number of patients diagnosed and treated with iNPH. You see that 75%, the dark gray bars represent performance before surgery, have the broad-based gait, 65% had shuffling gait, and 30% had freezing of gait. So this is the less common of the three signs. I will come back to diagnosing earlier stages of disease a little later in my presentation. But not all patients show these cardinal signs. Other signs we look for, here is retropulsion, again 47% before surgery, so around 50% had this sign. We also find that about a tenth had signs of cerebellar dystaxia that disappeared significantly after surgery. Another sign is the rigidity called paratonic rigidity, which in early stages is seen by patients having difficulties relaxing, trying to help you when you test the rigidity. In later stages, it's more like a firm rigidity, impossible to move, especially the lower extremities are affected by this. So in this study, 73% had paratonic rigidity, and this is something you should look for when examining patients. Okay, that was a lot about gait and balance, but I also want to stress some points for cognition. And there are a lot of, or there is a range of neuropsychology findings when these patients are tested. And in Gothenburg, we work along two main axes. We look for executive functions, which is the very typical dysexecutive performance in iNPH patients. It's a subcortical cognitive disorder, just like vascular dementia and some other disorders. For instance, a typical Parkinsonism can have the same type. So executive functions are reduced. Memory and learning, psychomotor speed is reduced. You see, these are old studies, but the problem remains. So that is one axis of the performance. The other part we look for is organic psychic syndromes, mainly impairment of wakefulness, which is typical for all types of hydrocephalus, not least the acute hydrocephalus. You can have this in a slight degree where patients show an increased need of sleep and daytime sleepiness. Another thing is the lack of initiative, the apathia that many patients describe, that they sit in their chair all day or just watch TV without any initiative, doing something they really like. Okay, so when testing patients, you should have a set of a few neuropsychological tests that capture these signs. And this is from Per Hellström in our group, who developed a test battery that we use, that we find very useful, with some tests catching these different types of symptoms. Here displayed as performance related to the reference population, healthy controls, where 100 is the results of reference population. Patients with the white bars represents patients before surgery, so you can look at them. So in all these tests, patients with iNPH perform worse than the reference population, and you see increases after surgery. Sorry, I said the black bars are preoperative results, and they climb up towards the reference population after surgery. In Gothenburg, we use these tests. It's the Ray Auditory Verbal Learning Test and the Stroop, which consists the Swedish Stroop test, which is a test of executive function. 2 tests, and we also have the Groove Pegboard, which is manual dexterity. Using these tests and some instrumental screening, we can also find evidence of other dementias, especially signs of Alzheimer's disease. So this is just illustrating the Stroop color word test. The first easy part of the test is where you just has to tell which color the box is colored with. So it's red, yellow, blue. The next test, which is the interference, is where you should again name the color and not read the word, which is very, very difficult if you have this executive function. You can try sometime. Okay, the last one of the 4 is the urinary urgency and incontinence, and it's a neurogenic bladder disturbance, a loss of inhibitory control, and it can be developed into bowel incontinence as well. And this can be everything from no symptoms at all, starting with urgency, then leakage that becomes more frequent until you lose complete control, lose control of the bladder, which empties itself by itself, really, and you have to wear a napkin. And this can be very socially disturbing, of course. It should be noted that urinary problems is common among elderly, so it's important to, especially because here you need to use the history mainly, if you don't have the help of a urologist or gynecologist in women, that this should be the urge type of incontinence, not the stress incontinence, where coughing or sneezing, etc., leads to leakage. In Gothenburg and in many other centers, we use the iNPH scale for assessment of these symptoms, and this can very nicely illustrate the performance of a patient. If you have the full rhomb colored green, then you have the normal performance in all 4 domains. The smaller this rhomb is, the more symptoms you have. So this illustrates a preoperative performance and a postoperative performance with increased values in all domains. Okay, I will finish this off with a few videos illustrate how different patients with iNPH can appear. So this first one is, I think I'll do like this. Do you still hear me? Yes. So this patient has a quite typical gait, iNPH gait. You can also look at her facial appearance. She looks very blunt. But if you look at her legs, she has an increased width. She has, well, maybe a slight increased foot angle. She takes many turns turning. She has a risk of falling, definitely. And her husband has to guard her all the way. And it's a very, very slow gait. But she doesn't shuffle that much, though. So this is quite typical, I would say, apart from the shuffling. The shuffling can appear when a patient has walked for some time. So that's also a good thing to extend the walking a little bit. So this is another patient with an iNPH gait. All these patients have been operated on. And this is not as typical as the first one. But you see the gait is quite slow. And you can hear the shuffling. Difficulties turning. You should be able to turn as a pivot turn. This example, the third one, it's also an iNPH gait. And I don't want to confuse you because this is just to illustrate that all patients do not look the same. And of course, it's important when you diagnose the patient. We want to diagnose patients before they are so severely affected by disease that they are hardly able to walk anymore. And this illustrates a little earlier gait disturbance. All these patients have agreed on letting us use their movies. She has this outward rotation. I haven't mentioned the arm movements. So if you see a patient like this, how are you to decide if this is iNPH or not? This patient is helped by two persons. And you can see she has the gait arrest here. But she has a quite narrow gait, but has extreme difficulties moving her feet. So you need to look for different signs. And in some patients, you see some signs. In other patients, you see other signs. And it's more difficult in early phases and in very late stages of disease to distinguish the typical picture. The last one here. He has the broad-based gait, the outward pointing of toes, difficulties turning, and you can see his arm movement is almost exaggerated. I would say also quite typical. Difficulties walking backward. You should be able to take much longer steps. And Eleanor is guarding him there. Okay, I just want to finish by saying a few words about the multidisciplinary team, which I would really recommend if you are to set up your own iNPH clinic. You should collaborate, and this is also much of what is so fun, great fun with working with these patients. Neurosurgeon, of course, neurologist, should have a physiotherapist doing the examinations. If possible, a neuropsychologist adds an enormous value to the team and to the diagnostics. And in Gothenburg, we try to base our diagnostics on the clinical syndrome and the typical MRI picture. We use CSF biomarkers for excluding other disorders, but also looking for typical patterns, which there are. And we used the additional tests when we are uncertain, but not in all patients. And this is supported by, for instance, the Japanese guidelines, where you can go to shunt surgery all the way if you have a typical symptomatology and MRI. And we looked at the number of TAP tests we had performed in some years and concluded that only slightly above 20% of the patients had been TAP tested before shunt surgery, whereas we use also lumbar infusion test. But the vast majority were operated on without either TAP test or lumbar infusion tests. And we have published studies using these diagnostic algorithm with very good improvement rates. So by this, I want to give the final message, and I'll be happy to take questions. The clinical syndrome of iNPH may be distinguished. In the workup, you should include evaluation of both history and signs of the iNPH symptomatology. Of course, looks for signs of other mimics or comorbidities because they may have a large impact on outcome. The use of the NPH multidisciplinary team, and that it's possible to use clinical symptoms to diagnose patients and decide for shunting. So thank you very much, and hope you have enjoyed my talk. I'd be happy to take questions.
Thank you, Mats. This was a very nice talk, and I think one of the most important words you mentioned them in the beginning of your talk, it was dedication, and you could hear that you and your team are dedicated about this disease. And as neurologists sitting here together with neurosurgeons and hopefully some neuroradiologists as well, we may have to talk about brain ductus again. What would you think? If you see a patient developing a gait disorder, what's more likely? Is it Parkinsonism or is it iNPH?
10 years ago, I would say Parkinson, but when looking at the recent figures we find of incidence and prevalence, I would say 50-50 really, because if you look at the incidence, the incidence of iNPH according to those studies that are out there is equivalent to Parkinson's disease, and so you should definitely consider iNPH because patients are in the same age. Parkinson's may start a little earlier in some cases, but if a patient is over 60 and has this type of gait disturbance, you should consider iNPH. Thank you for a good question.
Thank you. And maybe Mansoor, what you would like to pitch?
I think that was a very poignant question, Katarina. One thing that is coming out in the questions from the group and also what Mats has finished off with is perhaps a very understandable area, but also a slight controversy depending on where we work, is how you make the diagnosis of NPH. Still, in my practice anyway, we do the testing, but I can understand that 20 to 30%, depending on which data you look at and which publications, who don't respond to a test still benefit from a shunt. And if you've got a very good algorithm and good diagnostic setup, I sympathize that you can actually go ahead and do the shunting there. If you could provide more convincing evidence, maybe in a short statement, or if they could guide us, particularly those who are asking a question, is it enough just to look at walking down the corridor, or do we need to do the test?
I would say you could either, I mean, this is somewhat not provocative, but I know that what you need is to have you should rely on your ability to distinguish symptoms. I wouldn't shunt a patient just by looking at him or her walking 10 meters back and forth. I must do the full examination and the neurological examination and at least some cognitive assessment and and assessment of gait and balance. But I'm definitely convinced, as we are working in this way, that you can, by doing that, you don't have to do extensive invasive tests apart from LP pressure measurements and biomarker analyses if you have the typical MRI picture. So by having a team where you rely on each other, your experience, your surgeon relies on the team, it's definitely possible to have an algorithm like that.
Thank you.
And I'm not saying we shouldn't have tests available. For there are many patients that need to be tested, but not all, because you risk excluding patients on the wrong for the wrong reason from treatment that is very effective in most of the patients.
But to summarize, as Naren is asking, the majority in your practice, you don't need to test. You've got a good system.
Yes, if you have a selection and you perform the tests and find the right signs, you don't need to do additional testing.
Okay. Thank you very much, Mats. I think the rest of the questions perhaps we could do after our second lecture, which I think also relates to which shunting and so on. But that was brilliant. Thank you so much. Okay, Katharina, you want to?
Well, of course, thank you. And then we can listen to Kerstin Antwin. She works with Mats Stolberg at the Hydrocephalus Research Unit, and she will now present on how symptoms might predict the outcome, or maybe not. And we are happy to listen to her. Thank you.
Thank you for the invitation to talk here tonight. So, clock is ticking, and I will try to go through this without keeping you up all evening. So I'm going to present to you some data from the Gothenburg prediction of outcome in iNPH study. This project was designed to explore the predictive value of clinical CSF and MRI markers on the outcome after shunt surgery in iNPH. Because as we already discussed, there are no, to date, we don't have any really good clinical tests or hydrodynamic MRI CSF markers. None of these tests can reliably predict which patients will in fact improve from shunt surgery. So the positive predictive values are high in many tests, but the negative predictive values are low, meaning that we cannot rule out the shunt effect in patients with a negative test. So concerning the clinical symptoms, there's not so much data published on if they can be used to predict outcome. Although it's appealing because it's something that's easily available when meeting and examining a patient. So that's what we wanted to look into. And I wanted to briefly go over what is our routine iNPH workup, but I think Mats already went through it sort of, but I will just summarize that we have clinical assessments by neurologists, specialized physiotherapist and a neuropsychologist, of course an MRI of the brain, and we perform LP in patients for analysis of CSF biomarkers. We summarize these results and discuss at the multidisciplinary conference with a neurosurgeon, and where we make the decision of whether to offer a shunt surgery to the patient or not. And we use CSF drainage test and lumbar infusion test as supplementary tests in selected cases. In patients that are fragile or with multiple comorbidities that we think have high surgical risks, or patients with not so typical symptomatology. And we rely on the diagnostic guidelines from 2005. So we spend a lot of time interviewing patients about how did your symptoms start and how did they go on. So we want to capture an insidious start and a progressive course of symptoms. And the gait and/or balance impairment is mandatory, and at least one of the cognitive or bladder disturbance. And of course, hydrocephalic radiology and a normal CSF lumbar pressure. So for patients who go on to shunt surgery, so I'm going through this workup and the routine, how do we work with the patients, also as a background for the study that I'm going to present, because this is how patients were assessed in the study. So the standard procedure is a right frontal location of a VP shunt, sometimes a VA shunt, and most commonly it's a Medtronic Strata programmable valve with an anti-siphon device, which is primarily set at 1.5. After 1 month, patients are followed up with a phone call from a hydrocephalus nurse. And if patients are not improved, they will do a CT scan, and then we plan further individually. After 3 to 6 months, they come back to the hydrocephalus unit, and we repeat the clinical assessments and a new MRI. So this paper was published in the beginning of this year in Journal of Neurology, and already the title tells you the main result of the study, that symptoms and signs did not predict outcome after surgery. And this was in 143 iNPH patients. Patients were included in 2 centers, and those that were finally included in the study were patients who had the diagnosis, who had shunt surgery, and who had been followed up. Also at the follow-up, we excluded 8 patients, 3 because of complications, and 5 because of comorbidities that had progressed until that time point, so that we could not readily assess the effect of the shunt surgery. And we used the iNPH scale. So Mats already explained that we see this symptom constellation as a tetrad with 4 domains: gait, balance, neuropsychology, and continence. And the scale is a composite scale that uses different tests in all these 4 symptom domains, and a calculated total iNPH scale score ranging from 0 to 100, where 100 represents a level of healthy elderly population. We set the cutoff for improvement after surgery to improvement by at least 5 points on this scale. And in this definition, 73% of the patients were rated as improved and 27% as non-improved. In all these 4 subdomains and in the total score, there was significant improvement after surgery. And so let me go through the different tests pre and post surgery. All the gait and balance tests improved. So that was the timed up and go, walking 3 meters backwards, the number of times to stand up in 30 seconds, and the number of steps used to turn around, and also number of seconds in the Romberg's test improved. We recorded different neurological signs that we consider typical for the hydrocephalus syndrome that Mats told you about, and could see that the proportion of patients with these signs were lower after surgery. So that was shuffling gait, which was seen in about half as many after surgery, broad-based gait, freezing of gait, paratonic rigidity in the legs, and retropulsion. We also recorded if they had cerebellar dystaxia or focal neurological signs, which was seen to a lesser extent, but not reaching significance after surgery. In the cognitive testing, I already mentioned that in the iNPH scale, there's the neuropsychology subscore that consists of the 4 neuropsychological tests that are selected to capture the impairment in iNPH patients. And there we can see a significant improvement. But in the mini-mental state examination and 2 other memory tests, we did not see a significant improvement. The hours needed to sleep per 24 hours decreased. And we could see a significant improvement in the modified Rankin scale with a preoperative median of 3, meaning that meaning a level where a person is not able to live an independent life, to postoperatively a median of 2 with functional impairments but able to live an independent life. So, but the aim of the study was to see if we could find factors that would predict the outcome, and starting to look at different factors and comparing them between the improved and non-improved patients. We looked at demographic factors, comorbidities, the results on the iNPH scale, and in the different clinical evaluations and tests. And the result is that no, we could not find a difference between improved or non-improved patients in the baseline variables. And we also did a logistic regression analysis to find if we could find a predictive value to see who would improve based on these factors. And all the odds ratios for all the listed factors are close to 1 with a non-significant p-value. So again, no, we could not find that the baseline variables could predict which patients would improve. We did find some weak correlations, starting with age. We could see that the degree of improvement after surgery was 0.3 points lower per additional year of age, which is a very small effect. Also, we could see that the number of affected domains of these 4 symptom domains, if the patient had more domains affected, they were more likely to have a better improvement. But as a comment, also, if you have more domains affected, there are more symptoms that can improve. But concerning all the other variables, there were non-significant results in linear regression analysis. So we have a habit of interviewing the patients also about the duration of symptoms, which is often a very difficult question to assess, for patients to answer, when did these symptoms start? And we did not find a difference between the improved and non-improved patients. So the symptom duration was same in both groups. We asked them about what was your first presenting symptom? And we could not see that a specific symptom would tell us that the patient would be an improver or not. And we also asked about the dominating subjective complaint. So what is your worst symptom? Is it gait, balance, memory, incontinence, headache, or something else? And we found that patients who responded, memory is my worst symptom, that were 18 out of 143 patients. They improved to a lesser extent. So the improvement rate among those 18 patients was 44% compared to 73% in the whole cohort. Although these 18 patients do not stand out as being older or performing worse in cognitive tests. So I've come to my conclusions. So the conclusions that we drew from this study was that impairments in these measured clinical tests are typical of iNPH because we can see that they improve after shunt surgery. But the extensive clinical data in our cohort could not predict which patients would benefit from shunt surgery. We found a lower improvement rate if the dominating subjective complaint was memory, although those patients did not perform worse in cognitive tests. And we conclude from this that absence of any specific sign should not exclude a patient from shunt surgery. We need to make a holistic evaluation. So also patients without the full tetrad of symptoms improved. The symptom severity was not a predictor. That also those patients with severe symptoms improve. And a higher age was only weakly correlated to a lower degree of improvement and it should not determine the decision whether to shunt a patient or not. And finally, that vascular risk factors or comorbidities did not influence the outcome. So thank you. I would be happy to hear your questions now.
Thank you, Kirsten, very much for this nice introduction of your very important work in Gothenburg. And might I ask, of course, for a study, you need to have cutoffs and define outcomes. But if you ask the patients who are in your not improved cohort, would they do shunting again? What did they themselves report? Can you tell?
My experience is that, yes, there are patients who say that they wouldn't do it again, but I think generally those patients who didn't have a good effect would still say that they are happy that they did it because they wanted to take the chance to get better, and they had been informed that we cannot guarantee an improvement. And yeah, so that's my clinical experience.
Thank you.
They are happy to have taken the chance.
Kirsten,
Yes.
thank you. Before I ask my question, just a little comment for our listeners, the audience. We will come back to some of their questions, but just for those who are asking about difference between lumbar petroculator shunt VA and VP, there's been other webinars on this, and just as a summary, they all work well. There's pros and cons for each, but I could just ask them to look at some of those webinars rather than focus on those questions. A quick question for both of you, Kirsten and Mats, perhaps one after the other. What do you say to patients who come with suspected NPH and you think they have NPH and they say, what will happen to me if I don't have treatment? And the other question is, what is the likely outcome if they have treatment long term? Sorry for those key questions, but I think they come up very importantly for patients and neurologists and neurosurgeons.
I know what I'm saying, but Justin, please comment. You're the
but I think there's good evidence to say that if you have NPH and don't do a shunt treatment, you will get worse, and their symptoms are not fully reversible. So there's a risk that if you wait and you get worse, then perhaps you will have an effect of the shunt, but not as good as you would have if you had done it before. So.
And could you say anything about the speed of deterioration based on their presentation?
So that's very individual between different patients, the speed of the deterioration. But on a group level, we can say that there's good evidence to say that they will get worse in all their symptoms.
And the other thing, of course, is that if you wait, the outcome is getting worse too. So that's the other. I mean, when we wrote this paper together, by adding the group who improved, and we should just remind everyone that by improvement we mean an improvement of at least 5 points on the iNPH scale. So it's not just a positive change. It should be a clinically significant change. If we add that group together with the group who did not deteriorate, we reached 92 or 93%, I think, of the patients. So maybe in the future we will also talk about slowing or hampering deterioration, stopping patients to become deteriorated. We are very much talking about improvement, which is correct. For the second question, I would like to say that also your research, Kerstin, has shown that the long-term effects are generally very positive, both in meta-analysis and in the study with follow-up up to 6 years, Kerstin, where patients were very happy with their performance. They felt better than before surgery, even up after 6 years, most of them.
I often hear the comment that, but patients get worse later. And so in general, patients, around 60% in the study that I've made from almost 1,000 patients from the National Quality Registry of Hydrocephalus in Sweden, about 60% say up to 6 years after surgery that they feel better. And also my comment is that we know that the natural course is, it's a progressive disease. And so if you get worse sometime after the surgery, where would you have been if you didn't first do the surgery and become better and then have the progression of symptoms? So I think you create a new kind of starting point from where you later will get worse. And we don't really have data to say that the hydrocephalus in itself gets worse. These are older patients with other diseases, and we don't really know if the hydrocephalus state is still active. I mean, those processes, or it's in fact just other pathological processes that will make some patients worse later.
Thank you very much. I think there's quite important questions which keep coming up, but Katharina, do you want to put any questions from the list, perhaps? There's some questions about imaging. Maybe if you think.
Exactly, there's. I think you've been mentioning you already look into imaging as well as a prediction marker, and of course we use that in diagnostics. And there are a question about very practical question, maybe for the major audience. Why you use MRI? You prefer MRI for follow-up, although you have a programmable valve. That's maybe the first, and the other one more going into research. Do you think we could use more in-depth imaging, maybe flow imaging or AI in imaging to improve further?
All questions are very interesting. I mean, for diagnostics, I would say MRI is superior to CT, not least since you want to exclude non-communicating forms. And it's not seldom that we find evidence of aqueductal stenosis in patients with suspicion of iNPH, which leads to a different treatment, etc. So, but for follow-up, I would say both CT and MRI is possible to use. We use the same protocol pre and post-operatively, MRI. We also do a lot of research on MRI. So for us, it's good. Regarding AI, I think in the near future, we will be assisted by AI. And I would especially like to have volumetric measurements of the ventricular system and different parts of it. That is one area I think that would improve our abilities to distinguish both diagnostic features and also follow up diagnosing of shunt malfunction. The introduction of a standardized visual assessment of imaging by the iNPH RAD scale has led to an enormous development within radiology and much more patients coming to NPH clinics than earlier. So AI, yes, but it has to be done, and we are not there yet. Did I miss something?
Mats, that's excellent. A question which I think is very relevant and follows on from what Katharina said. But if I may set the scene, we know it's very common, NPH, as common as Parkinson's disease after the age of 60, 1% at least of the population after 60, and it jumps to over 3% after 80 and so on. And we know they decline once they've started to present and have deteriorated. And the speed can be quite frightening.
Yes.
And we know they're better off with the good data you presented, that at 5 years, at least 60% are better off and significantly better off with CSF diversion. But how about age? What do you think about the impact of age? Let's say someone's after obviously just 60 or 65 versus someone who's 75 or 85. Do you think there should be a different approach?
No, I think, well, you should, if I start, you shouldn't set a age limit for treatment. Definitely not. We have treated patients above 90 years of age with very good results. Of course, single cases and not large numbers. But I mean, if you could add 3-4 good years to a 90-year-old person, that's definitely what they want. And we have publishing a paper from the Swedish Quality Registry looking at the age groups, and preliminary results says that the oldest group improves a lot too. So definitely that gives support to also including older patients. Of course, you need to be very careful looking at biologic age, risk factors, etc., and complication. But if you have a patient who has risk factor profile that is acceptable, you should definitely consider operating on a patient, even if the age is above 80, 85.
Kirsten, would that be also what you would suggest should be the case, no discrimination regarding age? Because we would all agree with that. Is that very, very sensible? But obviously taking into account physiological age.
Yes, I think so. We don't set an age limit, but I think in the very elderly patients, we really want them to have a clear hydrocephalic syndrome with
Yes.
dominating gait and balance disturbance. So someone who is 90 years old and with a poor cognitive performance, we're not likely to offer shunt surgery. But someone who is mentally okay with a typical gait and balance disturbance, yes.
Okay. Thank you. So one more burning question, which I think has some common ground with what's been asked by the audience, and then I'll hand over to Katharina, is this, that in Sweden, in Gothenburg, it's been stated we've got about 700 cases a year, Mats, 120 shunts a year, which is very good volume. I congratulate you on the detection. I think that's fantastic. And so that's a lot of surgery. And if we're not going to be biased regarding any age, which is great, what risks do you explain to the patient in terms of, oh, do you just pass to your surgical colleagues? What are the risks that you say to the patient in terms of risk of surgery versus chances of improvement? What do you basically quote?
That's the big question, and you have to put that in front of every patient, I say. And what we do is that we face this question very early on to not in detail explaining everything, but if a patient is not interested in surgery, neurosurgery, you should usually not carry on with the workup. So we try to assess the patient's how the patient feels about surgery. But usually we present all the risks and add the percentage risk. So I usually say that, I mean, luckily the most problems with many of the shunt complications refers to children and are less common in adults. But you should add the risk of having an infection, having a intracerebral hematoma, a subdural hematoma or effusion, and a shunt obstruction. And results from the Swedish Hydrocephalus Quality Registry adds those sums to around 15 to 16%, which is much, much better than 15, 20 years ago. On the other hand, you have usually a chance of 75 to 80% that you are in the group of improved patients. And for most of the patients, the favor of performing surgery outweighs the complication risks. But that is an individual evaluation. So that is another thing I always bring up, that this is done for each individual. In our center, we have an assessment made by the neuroanesthesiologist of every patient to give us an assessment of the perioperative risks, We always assess alcohol intake in patients because that is also a risk for complication. And patients who drink too much, they need to cut down before they get the shunt. But the bottom line is that for most patients, unless you have a very extensive comorbidities or other chronic disorders, is that the surgery is favorable for the chance of gaining is much higher than the risk of complication. We haven't talked about outcomes, quality of life, etc., but there are so many things that you can profit from with the shunt.
Thank you very much. Just before I put that question to Kirsten, is that we've been talking in the past about lumbar peritoneal shunt, VA shunt, VP shunt. I'm starting to offer LP shunt on the local. In Japan, majority are done on the LP shunts and even on the local. In Colombia, it's VA and so on. And there's a now whole range being offered across various units around the world. What do you do in Gothenburg, and do you think it makes much of a difference which one you go for? And in particular, about the risk of general anesthetic in terms of cognitive decline and impact on elderly patient. Do you think we should go down the local anesthetic route and more minimally invasive shunts?
Well, I think that's interesting with the lumboperitoneal LP shunts, but so far I don't think it has been performed in Gothenburg or not even in Sweden. But yeah, I think it's very interesting. So the routine in Gothenburg is ventriculoperitoneal VP. Patients who have had large abdominal surgeries previously, that we know, surgeons know that there might be problems with the connecting a drainage tube into the peritoneal cavity. They would choose VA shunt instead. Or in patients who first had a VP shunt and it didn't work in the peritoneal part, and they shift to VA shunt. Yep.
I agree. I think as a neurologist, I would rather avoid putting a shunt into the brain. So I try to advocate the introduction of this LP shunt technique outside of Japan. So I think that this will get, the interest for this will be increasing in the coming years, because I mean in Japan they do the LP shunt in around 50% of iNPH cases. There are some complication problems and things like that, and maybe the technique can be even better when developed, but it's a more cautious way of draining the CSF.
Thank you very much for that. It's it seems to be the same in every unit. People get more comfortable with a particular technique, build up experience, and carry on with that, and that's very understandable. Thank you both. Katharina, do you think there's any other remaining questions from the audience that we should ask?
I think maybe if we stay in the same section of VP shunting versus lumbar shunting, and there were some questions about follow-up after shunting. So for one, the experience that you have a decline, what do you do after a while once the patient declined after shunting? How do you react on that? And there was ultimately a question, when do you stop alternating the shunt?
This is a very tricky question. There is not very good evidence that reducing shunt valve pressure, differential pressure, leads to improvement. But there are, on the other hand, some studies, and there are individual patients that seem to benefit from adjusting the shunt valve. So if a patient comes back with deterioration, my first question is if the shunt is really working. So you should always start by assessing shunt function. And that's also a good thing. If you have a good workup before surgery, including clinical tests, including good neuroimaging, you can compare. So you can look at what was the performance on the TAG or the 10-meter walk test before and after surgery, then compare with a new performance, and you can compare imaging. Sometimes you see that no, it's the experience of the patient, the performance is as good, it's still better, or it's back to what it was before surgery, which increases the possibility of shunt malfunction. Then you should also, of course, perform a shunt function test, and there are a few you can use. We use the radionuclide shuntography and the lumbar infusion tests mostly. First, a new brain CT usually. But if the shunt is working, then you may try to reduce the setting, but be very careful. We need studies looking more deeply into this. I know that some, as a routine, change the shunt setting, but we don't do it in all patients. We really try to find out what is the problem, and sometimes it's aging, sometimes it's another disease or disorder that causes a change. Especially if you have a deterioration in one of the 4 cardinal symptom domains, which speaks against the NPH coming back. I hope that was an answer, but be careful, do a thorough workup, and focus on the shunt function. And in some cases adjust, but check for subdurals if you reduce the pressure.
Thank you. I think we're coming back to dedication in patient care.
Yes.
Again.
Katrina, is it okay if I ask one burning question?
Of course.
Which is a question I've had from the beginning of this webinar. We know it's common, very common NPH. We covered that 1 to 3% of the population is over 60 or 80. We know the treatment is, although variable, there are tests for it, there's good diagnostic yields, and the treatment works. But could you please let us know why it is that we don't treat as much as we should be? Because if you look at the numbers of patients who have NPH, there's little doubt, there is in fact no doubt by all scientific evidence that they're better off with treatment. Why is it that we're not treating as many as there are out there? Thank you.
Well, should I start, Kerstin, or do you want to?
You go.
I think there are a few main reasons. One is that this is a disorder affecting elderly, so it's often mistaken for age, so that's one thing. Another thing is that it's both a disorder of movement function and dementia, which makes, and it's also a mix of neurosurgery and neurology and geriatrics, etc., which makes it more difficult to have a clear line of a work or flow process for the patient. You need to be caught by some interested specialist, and many patients are misdiagnosed, not least as a dementia of unknown kind, mixed dementia or something like that. So that's the second thing, I think, so that we need to work on that. The third one is that we don't have a diagnostic marker that is good enough. So you have to do a lot of examinations. You have to do either a full clinical examination. You can use the infusion or drainage tests, picking patients who respond. But we need to elaborate a better or more robust diagnostic test. That is one of the main challenges for research, and of course also better prognostic tests. The fourth one may be that it's a surgical intervention, which is of course something else than trying some drug for 3 months and see if a patient responds. So I would say those are the main reasons. The fifth may be the difficulties with radiological imaging, because earlier on, before we started to make progress within the standardized evaluations of scans using the RAD scale, many patients were lost due to inability among radiologists to really suspect iNPH. So put together, all this makes it difficult, but I'm definite in my view of this that we are moving in the right direction, and I expect a lot of things happening within the coming years, which will mean a challenge to healthcare. And we all need to work hard to make our managers realize that this is a patient group that needs attention.
Thank you, Matt. Kirsten, do you have any additional comments?
I think Mats said it all. I'm just thinking about that. Of 3 patients coming to our hydrocephalus unit for evaluation for shunt or not, of 3 patients, 2 will have a shunt and the 3rd will not have a shunt. But that 3rd person is also someone with hydrocephalic image, radiological image, and with symptoms that would maybe be NPH. And for some reason we decide that sometimes we decide that this patient has an NPH, but we do not recommend a shunt for some reason, or that it's in the end it's not typical for NPH. But I think, as Mats said, the diagnostic, we don't have a strict diagnostic marker to say what is NPH. So how many people are out there that should have a shunt? We don't actually know that number. Should everybody with these signs have a shunt? We don't, in fact, know that. I'm convinced that more people than we shunt today should have a shunt. That there are much more people out there that can have a good effect if they were offered shunt surgery. But should we offer a shunt to 1 to 3% of people over 60 years of age? I don't know.
Thank you very, very, very much for dealing with all the controversies and all the main questions. Very, very grateful.
May I also jump in with a question, Mansoor?
Of course, I'll leave
Thank
it.
you. Thank you so much for the wonderful presentations and the fantastic discussion. I'm wondering, and I think some of the audience also, what does a journey stop if an elderly patient is reluctant in going ahead with surgery? What do you offer them? Do you offer what conservative treatments do you have? How do you follow up them? Do you offer lumbar puncture, repeated lumbar puncture, any medication? How does the story go on in a patient that is reluctant undergoing surgery, but you are quite sure they would profit? What do you do?
Well, that's definitely a reality. And first of all, you must respect the choice of the patient. What we do is to offer a time for consideration. So usually we offer them to come back within some weeks, or come back if they have changed their mind. I have a few patients I have treated with the repeated lumbar puncture over the years, and mainly it's patients who where the neurosurgeon did not want to operate on the patient, and the patient was desperate. But that's usually for a short period of time in an old patient. Otherwise, I think you have to be open-minded and accept what the patient says, but also inform the patient that the decision should not wait too long. It's better to do it than to wait and risk losing function and having a poorer prognosis. And we have quite a number of patients who declined and who come back a year or 2 later, having changed their minds because the symptoms have developed. And it's a bit sad to find them being much more affected by disease perhaps starting to lose gait function. So there is, we don't use acetazolamide or any medication. So it's in very rare cases lumbar puncture, perhaps to see if you can strengthen the indication for operation or surgery, or make the patient experience an improvement that may help them in their decision. But it's difficult, and some don't want to be operated on in their head, and you have to respect that. Don't you think, Kerstin?
Yes, I met such a patient the other day. She was firmly decided that she did not want to make a brain operation. And we need to respect that.
And would you think she would do lumbar shunting?
I don't know. I could not offer
Yes,
that.
offer her to go to Japan. That's a good
Very
question,
tough
because
about
I would. What would you self choose? I would rather have a lumbar shunt, LP
London or
shunt.
Germany is closer.
Yeah.
But
London,
we could
London,
come
of
there.
course. Yes.
Yeah.
I don't think we could make all of the questions, and there were many questions also going into pathophysiology and how we should understand how NPH actually works. And I think we could have 2 other webinars about this, and also some more questions on like what to do follow up. And I think it just underlines how important this work is and how important it is to catch up on those. You get up a number of 1.5% in the age of 70 and 3% in the age of 80, and we're all getting older. And probably we should pick this up and put this into next year's webinars, if my co-moderator agrees. Perfect.
Absolutely. Thank you, Kerstin.
And then I would like all the audience, we had more than 100 listeners today, and we will put this live on the YouTube channel of the EANS. We thank the EANS office for the support. And we would like to wish you a good night and see you next time for the webinar series.
Thank you very much, and thanks all for listening. Hope
Thank
to
you,
see
Mats.
you
Thank you,
again.
Kerstin.
Thank
Thanks,
you very
everyone.
much.
Bye. Thank you.
Thank you. Bye-bye.